insertion, feeding, and removal of nasal gastric tube. Before to start, I am going to introduce my supplies. I have here nasal gastric tube, Macintosh, syringe, flashlight, marker, fan compressor, 50 syringe. I have also here seesaw, 50 basin, cotton balls, and medical tape. Inserting a nasal gastric tube. It is defined as a method of introducing a tube through nose into stomach. There are 5 purposes of nasal gastric tube insertion. First, to treat client with fluids when oral intake is not possible. Second, to dilute and remove consumed poison. Third, to instill ice cold solution to control gastric bleeding. Fourth, to prevent stress on operating site by decompressing stomach of secretions and gas. The last one is to remove vomiting and distension. In inserting nasal gastric tube, first, we need to check the doctor's order for insertion of nasal gastric tube. This clarifies procedure and the type of equipment required. I'm going to check the doctor's order for the insertion and feeding of nasal gastric tube. Second, explain the procedure to the client. Explanation facilitates client cooperation. Good morning, ma'am. I'm Arvis Sagada. I am your caregiver for today. I'm going to perform your nasal gastric tube insertion, feeding, and removal. How do you feel today? Do you have any questions, ma'am? Can we start now? Next, assist client's abdomen. Assessment determines presence of bowel sounds and amount of abdominal distension. Assist the client to high collar's position of 45 degrees if unable to maintain upright position. Upright position is more natural for swallowing and protects against aspiration. The client should be. Then, check the nostril. Tube passes more easily through the nostril with the largest opening. Check the nares for patency by asking the client to occlude one nostril and breathe normally through the other. Clean the nares by using cotton balls. Select the nostril through which air passes more easily. I'm going to check your nostril. Can you breathe using the other nose? Okay, thank you. Next. Thank you. After checking the nostril, I'm going to clean the nearest. Measure the distance to insert the tube by placing 1. Place the tip of the tube at client's nostril, extending the tip of the air loop. Extend it to the tip of the xiphoid process. Mark tape with a marker pen or a piece of tape. Measurement ensures that the tube will be long enough to enter the client's stomach. I'm going to measure this. Lubricant, the tip of the water-soluble lubricant. Lubricant reduces friction and facilitates passage of tube into the stomach. Sickle jelly may not be recommended to use as a lubricant due to the risk of sickle shock. Water-soluble lubricant will not cause pneumonia if the tube accidentally enters the lungs. After maturing, I'm going to lubricant the tip of the nasal gastric. Inserting the tube. Insert the tube into the nostril while directing the tube downward and backward. Following the normal contour of the nasal passage, while inserting the tube reduces irritation and the likelihood of mucosal injury. The client may gag when the tube reaches the pharynx. The gag reflex stimulated by the tube. Instruct the client to touch her chin to her chest. Encourage her to swallow even if no fluids are permitted. Swallowing helps advance the tube, pushes the epiglottis to cover the opening of the trachea, and helps to eliminate gagging and coughing. Advance the tube in a downward and backward direction when the client swallows. Stop when the client breathes. If gagging and coughing persists, seek placement of the tube with a tongue pressure, and flashlight if necessary. Excessive coughing and gagging may occur if the tube has clogged in the back of the tube. If advancing the tube until the marking or the tape marking is reached. Do not use forks. Rotate the tube if it meets resistance. Forcing the tube may injure mucous membrane. Discontinue the procedure and remove the tube if the tube are signs of distress, such as gasping, coughing, cyanosis, and the inability to speak or hum. The tube is not in the esophagus if the client shows signs of distress and is unable to speak or hum. Verification to touch this chain protein. What can you touch your chain protein, please? And this swallow, please. And please. By keeping the hand of the tube, verify the tube's placement in the stomach. By aspiration of a small amount of stomach contents, the tube is in the stomach, its contents can be aspirated. Attach the syringe to the end of the tube and aspirate small amount of stomach contents. Visualize aspirated contents, checking for color and consistency. Auscultation. Inject a small amount of air, 10 to 15 milliliters, into the nasogastric tube, while you can listen with a stethoscope approximately 3 inches, about 3 centimeters below the sternum. going to integrate. Unless empty. The tube is in the stomach. You will be able to hear the air enter the three oozing sound. The tube is in the esophagus. The tube is in the esophagus. Injecting the air will be difficult or impossible. In addition, injection of air often causes the client to belch immediately. The tube is in the larynx. The client usually is unable to speak. Obtain radiograph for placement of the tube as ordered by the physician. Secure the tube with the tape to the client's nose. Be careful not to fold the tube too tightly against the nose. Constant pressure of the tube against the skin and mucous membrane causes tissue injury. Clamp the end of the nasal gastric tube while you bend the tube by fingers not to open. Put off the gloves and perform hand hygiene to prevent the spread of infection. Administering the nasal gastric tube feeding, a means of providing liquid nourishment through a tube into the intestinal tract when client is unable to take food or any nutrients orally. Purposes of nasal gastric tube feeding. First, to provide adequate nutrition. Second, to give large amounts of fluids for therapeutic purposes. Third, to provide alternative manner to some specific clients who have potential or acquired swallowing difficulties. Administering nasal gastric tube feeding. Assemble all equipment and supplies after checking the doctor's prescription for tube feeding. Checking the prescription confirms the type of feeding solution, route, and prescribed delivery time. Prepare formula. Formula loses its nutritional value, can harbor microorganisms if kept over 24 hours, and cold formula cause abdominal discomfort or sometimes diarrhea. In a type of liquid which prepared by hospital or family, at a time, make formula at a time and allow formula to reach room temperature before using. Perform hand hygiene and put on disposable gloves. Position the client with the head of the bed elevated at least 30 to 45 degrees angle. And her position helps avoiding aspiration of feeding solution into lungs. Permanent placement of feeding tube by occultation and injecting 10 to 20 milliliters of air into tube. Intermittent or bolus feeding using the syringe. Clamp the tube, insert the tip of the large syringe with plunger or valve removed into the gastric tube. Then pour feeding into syringe. Place the into. Put this on there. Raise the syringe 12 to 18 inches above the stomach gravity. Promotes movement of feeding into stomach. Then open the clamp. Allow feeding to flow slowly into stomach. Raise and lower the syringe to control the rate of flow. Controlling administration and flow rate of feeding prevents air from entering the stomach, anosmia, and abdominal cramping from developing. Then add additional formula to the syringe as it empties until feeding is complete. Terminate feeding when completed. Add additional formula. Terminate feeding when completed. Insert prescribed amount of water to maintain patency of the tube. I'm not going to distill the water. Keep the client's head elevated for 20 to 30 minutes because his position is carried with aspiration of feeding solution into the lungs. After feeding the client, provide mouth care by brushing teeth. Mouth care promotes oral hygiene and comfort. Offer mouthwash and keep the lips moist. Document date, time, amount of residual, amount of feeding, and client's reaction to feeding. Then go to documentation. We're done. Removal of nasal gastric tube. Assemble the appropriate equipment such as kidney tray, tissues or gauze, and disposable gloves at the client's bedside. Explain to the client what you are going to do to foster health operation. Good morning, ma'am. I'm Maricruz Sagada. I'm your caregiver. I'm going to remove your nasal gastric tube now. Do you have any questions, ma'am? Can we proceed now? Thank you for the answer. Take off the adhesive tape which holding the nasal gastric tube to the client's nose. Then remove the tube by deflating any balloons. Do not remove the tube. If you encounter any resistance, not to harm any membranes of organs, just do another attempt. Click to remove your nasal gastric tube. Simply pulling it out at first and then rapidly. When the client begins to cough because continuous slow pulling it can lead coughing or discomfort. Then conceal the tube. Going to take the nasal gastric. Continue holding. The client is coughing. Be sure to remove any tapes from client's face. You can use acetone. Acetone may be necessary. It helps any adhesive substance from the face. You should wipe acetone out after remove. Now in your nose, ma'am. Tapes because acetone remain on the skin may irritate. After removing the nasal gastric tube, put off the gloves and perform hand hygiene to prevent the spread of infection. Dispose the equipment and replace them. Record the date, time, and client's condition, and be alert for complaints of discomfort. distension or nausea after removal. Thank you for your cooperation, ma'am.